Good morning, everyone, and welcome to the final day of the International Stroke Conference 2026. How are you, Bijoy?
You know, uh, I must say I'm a little bit tired with all the excitement, but I'm just joking. It's been an exciting couple of days. Today is the last day of the conference, and I'm just looking forward to the next set of exciting studies that we would have at the plenaries.
Yeah, there's going to be a number of trials on neuroprotection that'll be shown, both in the preclinical, randomized clinical trial space and in 3 trials in patients, with one showing benefit, lobrasimol, in a large trial, and another compound of 4 Chinese herbal medicines that is also showing a benefit, and then some signal for LT 3001. So promising excitement on the neuroprotection front.
I'm really excited about the loberimisa compound. So this seems to be a drug that works on two promising targets. One that we already know about, PSD95, and then also on the GABA receptor, and possibly because of its dual effect on these receptors, that it is actually showing that it helps improve outcomes in patients with acute stroke. So, what do you think about the compound and the trial,
Well, I think
Lauren?
it's great, and maybe its benefit is that it not just hits PSD95, but also this sort of GABA pathway. I think that because there's a 48-hour window, it potentially could reach so many more patients than some of our hyperacute neuroprotectants. And so, I look forward to it being replicated in a larger global trial, but I think it has a lot of promise.
The other trial, again coming from Asia, I think is also very interesting. For long, I've always believed that there's a lot of unknowns that we have in traditional medicine, and I think with this particular trial now showing promising results, that it actually opens up avenue for us to explore more about what some of those traditional medicine medications might offer. Obviously, like in the 21st century, we do need to create evidentiary framework around traditional medicine. But I was quite intrigued by this particular trial.
Right. And, again, it's 4 compounds in a capsule, and in a randomized placebo-controlled clinical trial is showing benefit on outcomes after stroke. So, that is the gold standard that we hold neuroprotectants and all medications to. And so it's really fantastic to see some of the more traditional medicines coming in, getting tested in that, and showing a benefit.
I must say, the one trial that I, felt really affected by was the pediatric stroke trial
Yes.
I acquired. And so this was a trial that was to actually find out if we have an intervention that helps infants with stroke. And I do not know whether, you know this, but 1 in 1,000 infants do have strokes. If you look at the number of births in the US or in the world, a significant proportion of babies, right? Or number of babies that affect families. And so, Lauren, like, what do you think about the I acquired trial results?
Well, first, an incredible kudos to the investigators for successfully completing this trial. Challenging to do physical therapy, constraint-induced movement therapy with infants. Obviously, it takes the whole family to be fully engaged. And the intensity, the 2 intensity levels, right? One was 3 hours a day, 5 days a week, 4 weeks. The other was 6 hours a day, 5 days a week, 4 weeks. So, incredible feat. And when you are, overall, there wasn't in the intention to treat, there wasn't a clear benefit. But if you look at the per protocol, the families that were and infants that were able to comply with that protocol in the high intensity group, that's where there was a significant benefit that lasted out to 180 days. And I think this is where we were both really touched, the quotes from the parents about
Right.
being able to sort of see the improvements and how the babies were moving. It was so empowering for them to offer something, and so I think there's obviously more to be done to sort of tease out exactly what are those thresholds and what is the best way to deploy therapy for infants with stroke, but really heartwarming and exciting to have something to offer this
And
group.
yeah, I agree, Lauren. And I also feel that, the more we do this type of research and the more it shows even just a little bit of promise, it actually, reassures and provides that encouragement for pediatric neurology researchers that yes, this is possible. And then that offers a ray of hope for
Yeah, and gets
families,
more research,
funding,
more
and
funding, more families excited about
that's right.
participating. So I think there's a long track
That's
ahead.
right. That's right.
And then do you wanna talk about some of the MeVO
That's
studies?
correct.
Yeah.
So, like that's an interesting story. Last year, our field went through a period of depression with 3 trials showing negative results or neutral results. For the audience, MEVOs are medium vessel occlusions. So these are when clots are not in the large arteries at the skull base, but in the more distal arteries. And so when we do the thrombectomy procedures, it's a little bit more complicated to get the device to these distal arteries. But the point is, these devices can reach there and possibly open arteries. But it is more complex. And so there was always this question about we can open these arteries, but can we do it safely? And overall, how does it affect outcomes? And so there were 3 trials, large trials, one that, my center was also leading. But these trials were all neutral. And so that was a bit depressing. But we now have 2 trials at the session today that seemingly might actually show us a different perspective with the possibility that this is not a shut door, that there might actually be an opportunity in these patients. That maybe this is a new device, or maybe this is a new technique or a certain group of patients who might actually benefit. What do you think, Lauren?
The question in my mind has been, do we just need device evolution, right, to more safely get into these smaller blood vessels, often less than 2 millimeters? Or is it that patients with these smaller arteries are having smaller strokes, thankfully, and therefore sort of other adjunctive therapies can get them to good outcomes, and just the opportunity for benefit is going to be too small for devices. I think the 2 trials, so one mevo trial from the Asian population, another trial using any device open to the investigator, and then there's the tiger triever device that was sort of specially designed for these smaller arteries. Both are reporting benefits in both recanalization rates, and then the Asian trial showing, functional benefits in the numbers of patients that are getting to a modified Rankin scale score of 0 to 2 was improved with thrombectomy. The tiger retriever showing recanalization, I haven't seen their clinical outcomes yet. But again, some excitement in the field that yes, maybe thrombectomy is the way to go. We just need to approach it in a slightly different way and select our patients better and select our devices better.
Yeah, I agree, Lauren. I have a similar take, and I think, like the story might be, devices that actually are suited for these small vessels in a patient population that might benefit. So the Asian trial on MEVOs did actually use what I would say, fairly a strict perfusion criteria, which meant that, these were patients who had potentially larger salvageable brains, even though they were distal occlusions. They did actually use 2 different imaging criteria, but the principle was the same. And so if you have the right devices and possibly the right patients, maybe that is where, the signal might lie with intervention in MEVO patients.
Right.
But
Yeah.
I think we do need more studies now to prove the
Well,
point.
that's great. More work to be done,
That's right.
but hope for patients. And I think that's the sort of message
That,
for many of our trials at ISC this year. And
that's correct. There were a few interesting studies, the plenary yesterday to
like option.
like option.
Yeah.
What do you think, Lauren, about option?
So, you know,
Offering us option?
it's offering us an option, a really cleverly named trial. So option is looking at the efficacy of tenecteplase in the late window in patients that aren't eligible for thrombectomy, and showed a benefit in those patients. Now, of course, there is selection criteria, imaging based, needing mismatch, but reassuringly, despite, sort of of course, expected sort of risk of tenecteplase place, the numbers of patients that did well was improved. Again, it's great to have something to offer. I think we'll, have to look at it again in a more global population, make sure that we're seeing the same signals here, but certainly promising.
Yeah, and no pun intended, but along the same lines, offering us different options where the two other trials from Asia, TNK plus and attention late, and these trials are now telling us that when you have thrombectomy on offer, then maybe and on offer emergently, which is that it is quickly available, then maybe tenecteplase intravenous is not an option.
Right.
And so, what did you think about those studies?
It's always wonderful when we have concordant trials that are giving us, sort of similar information. So, both in the anterior circulation and the posterior circulation now, we know that if you're about to go to thrombectomy, meaning the patient's there at a thrombectomy capable center, you're about to go, that giving tenecteplase right before thrombectomy, while there was sort of a signal that more vessels recanalize slightly, overall, the recanalization rate is great, and there wasn't any improvement in outcomes. So no need to do that. If their patient is there, you can go right to thrombectomy. It opens up the question of what do you do for bridging if a patient, shows up at a community hospital, needs to be transferred. Is there going to be a benefit in this, late window? But I think that's a separate question, not addressed by these trials.
Yeah, I agree. And then I think the elephant in the room, from my perspective, yesterday was the asundexian trial, oceanic stroke.
Right.
And it's been about I think around 5 to 6 years when the first DOAC trials came up with rivaroxaban, apixaban. And I think, like it's really exciting that now we have a new drug, asundexian, that can help prevent more strokes from happening. That gives us more options, but it also, think, in my opinion, attesting to the fact that as a field in stroke, we are evolving to where, it's not just one therapy, but combination therapies that might actually help patients. What do you think,
Yeah,
Lauren?
that's a great point, right? Because asundexian was added to standard antiplatelet therapy, right? And this
Yeah.
is patients that are having strokes from atherosclerosis, right? It's not AFib cardioembolic strokes, but particularly the non-cardioembolic strokes, that the addition of asundexian to aspirin or aspirin plus clopidogrel reduced the risk of recurrent stroke. And across all populations, all sizes of stroke. I think this was really a very convincingly positive trial, and now a new kid in our drug toolbox to prevent stroke.
And I think along the same lines, we used to, we have tirofiban, a GP2B3 inhibitor available for use intravenously acutely. But Yilong Wong and the Beijing Tiantan group presented on the tirofiban study in
Right.
branch artery atherosclerosis with strokes that would have, be perforator infarct. And I must say, maybe contrary to some expectations, the signal or the suggestion that tirofiban, in addition to aspirin, might actually be helpful acutely in these patients. I would say subacutely in these patients. I think the evidence was a little bit sort of, like muted. What did you think about that
Yeah.
trial?
I was disappointed, right? It
Yeah.
was a null trial. These patients often go on and sort of have a stuttering decline, and you wish you had something more to offer them. So I was hopeful, but unfortunately, a well done trial answered that question. I think for that treatment window in those patients that that isn't what our approach, and we need more options for them.
And finally, I think, there was the Embolize 2
Hmm.
trial too, and a completely different set of patients now. And we all know about the previous Embolize trial. And since then, there's been, at least around 4 trials that I'm aware of that has made middle meningeal artery embolization the standard of care in patients with subdural hemorrhages who are candidates for surgery. But this study was focused on trying to find out if people who were not candidates for surgery, whether they might actually benefit from embolization. Did it actually throw up more questions or? What do
Yeah,
you think, Lauren? So,
they showed a benefit, right? And they showed a benefit in reducing sort of neurological deterioration and subdural hemorrhage expansion, reducing the need for surgery in the future. And it showed actually reductions in volumes of the subdural volume. So, suggesting that you embolize and the MMA is no longer oozing, that perhaps then there's also enhanced resorption. But I think I'm a little unsure about the results just because there was a high loss to follow-up rate. There's a bunch of patients, 27%, I think, that we don't have the data on, but, promising. And that is on top of the positive results for patients that do receive surgical drainage first. So I think it makes sense. It follows along with the other evidence, but it was still, small numbers of patients and probably need some more data. All right. Well, thanks everybody and for coming to New Orleans, taking part in the science and the networking and the great opportunities from all the, professionals working in stroke clinical care and research. And thank you, Bijoy, and best of luck for next year.
oh, thanks. And thanks to all of you. The ISC is where some of the best science in our field comes out. And so thank you for those who attended the ISC. And we look forward to having you all in Houston next year for ISC 2027. Thank you.
Thanks.